Hey everyone, and welcome back to PodBites, where we break down complex medical topics into bite-sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm your host for today, Liano, here with my bestie, Romero, and today we're tackling one of the most common and most tested surgical emergencies you'll encounter in medical school and beyond, acute appendicitis.
This topic is extremely high yield. It shows up everywhere: anatomy labs, pathology slides, OSCEs, surgery rounds, and exam questions. It's one of those conditions where understanding the why behind the symptoms makes everything click.
Appendicitis isn't just about memorizing right lower quadrant pain. It's anatomy, embryology, histology, microbiology, imaging, and management, all telling one connected story. And if you're heading into clinicals, this is a condition you're almost guaranteed to see.
So today, we're going to build it slowly, starting with the appendix itself, then following what happens when things go wrong, and finally tying it all together with how we diagnose and manage it. All right, let's zoom out for a second and talk about why appendicitis even matters on a global level. Appendicitis is actually the most common cause of an acute abdomen requiring surgery worldwide.
Which means if someone shows up with sudden abdominal pain that needs an operation, statistically speaking, appendicitis may be your number one suspect.
And the numbers back that up. In the United States alone, more than 250,000 appendectomies are performed every year.
That's a massive surgical volume. Surgeons see this constantly, and exams love it for exactly that reason.
Now let's talk about the lifetime risk. Because for males, the risk of appendicitis is 8.6%, while for females, it's 6.7%.
Did you just say 6, 7? I'm sorry, I had to say that. So roughly 1 out of every 10 people will deal with appendicitis.
And age matters too. Appendicitis peaks between 10 and 30 years old, meaning the second and the third decades of life.
Which explains why it's so common in adolescents and young adults coming into the ER. Mortality from appendicitis is low early on, but once perforation occurs, mortality increases by 50-fold.
That's not a small jump. That's the difference between a contained infection and bacteria spilling freely right into the abdomen.
Which is why timely diagnosis is everything. Appendicitis itself is a stealthy killer. The delay is what'll get you.
And that's exactly why clinicians are trained to treat suspected appendicitis seriously and early. To understand appendicitis, we have to start before birth. The appendix is a true midgut derivative, and its embryology explains both its position and its pain patterns.
So, at around the 8th week of gestation, the appendix appears as a diverticulum from the apex of the developing cecum. As the midgut undergoes physiological herniation and rotation, the cecum migrates downwards, carrying the appendix with it, ultimately landing in the right lower quadrant.
The final position of the appendix depends on differential ventral versus dorsal growth of the cecum, which explains why appendiceal positions vary so widely.
Functionally, the appendix isn't actually useless. Early in life, it acts as a hematopoietic organ, and later becomes rich in secondary lymphoid tissue.
Which explains why lymphoid hyperplasia is a major cause of appendiceal obstruction, especially in children.
In neonates, the appendix is funnel-shaped with a wide lumen, making obstruction rare, which is why appendicitis in neonates is uncommon but extremely difficult to diagnose.
And all this time, I thought the appendix had no function. In Arabic, it's literally called zaida, the extra thing, which feels deeply unfair to the appendix.
Yep. But before we call anything appendicitis, we need to understand what the appendix actually is, because every symptom flows from its anatomy. Anatomically, the appendix is a blind-ended tubular structure arising from the cecum, about 2 to 3 centimeters below the ileocecal valve.
Blind-ended meaning contents go in, but nothing comes out.
Its length is highly variable, ranging from 5 to 35 centimeters, which already hints at why presentation differs so much between patients.
And since it's a midgut structure, it shares midgut blood supply, lymphatics, and innervation,
which becomes crucial for understanding pain patterns and complications. Now imagine this. You're scrubbing in, convinced you've diagnosed appendicitis perfectly. Then the surgeon turns to you and asks, how do you locate the appendix?
If you answer right lower quadrant, don't be surprised if they just kick you out.
This is where key anatomical knowledge comes in. The colon has 3 longitudinal smooth muscle bands called tinea coli. Imagine thin white ribbons running along the colon, and all 3 tinea coli converge right at the base of the appendix. This means wherever that point lies is where the appendix is, and that is how surgeons locate the appendix during procedures.
So from now on, you will answer the question, how does one locate the appendix, with the confidence of a surgeon and promptly say, well, you follow the Taenia coli, of course.
Yes, of course. Now, the base of the appendix may be anatomically fixed, but the tip is actually mobile.
And that mobility explains why appendicitis doesn't always read the textbook.
Bingo, right on the money. Now let's talk positions. The most common position of the appendix is retrocecal, meaning it lies right behind the cecum.
That's the classic presentation for right lower quadrant pain.
A pelvic appendix can cause suprapubic pain, urinary symptoms, or even diarrhea.
And if it's retroperitoneal, yes, even that is possible. The pain may radiate to the back or flank, which is why it can be confused with renal pathology.
This variability is why appendicitis is a diagnostic chameleon, especially early on. Now, imagine you're on a histopathology rotation. A consultant hands you a slide and asks, "What organ is this?"
First, you check its ID, the epithelium.
Well, yeah, but most of the GI tract has simple columnar epithelium, except the esophagus, which has stratified squamous.
So then you look for the villi.
Prominent or irregular? Now that's the small intestine, but complete absence suggests the large intestine.
So how do we know if it's really the appendix and not another part of the colon?
One word, lymphoid follicles. That's right, the appendix contains abundant lymphoid follicles in the lamina propria of the submucosal layer. It's actually its main feature, and this lymphoid tissue plays a huge role in appendicitis, particularly in children. In pediatric patients, viral infections can cause lymphoid hyperplasia.
First of all, those are two words. Second of all, you underplayed how big the lymphoid tissue gets.
Oops, you're right. It can obstruct the appendiceal lumen. That's why in children with suspected appendicitis, you should always ask about recent viral illnesses, even something mild like a cough or bronchitis.
So obstruction is really the star of the event here?
Always. Let's make this painfully clear, because examiners love this line. The very first event in what we call the cascade of death in appendicitis is luminal obstruction, not inflammation, not infection, obstruction, always.
If obstruction isn't there, appendicitis does not happen.
Yep, and the causes depend on the age. In children and young adults, it's usually lymphoid hyperplasia, often after a viral illness. In adults, think fecalis, and less commonly, but very high yield, parasites, foreign bodies, or neoplasms, especially in older patients.
So once the lumen is blocked, the appendix is basically trapped in its own secretions.
Yeah, that's low-key nasty. And these goblet cells don't get the memo. They keep producing mucus, but now there's nowhere for it to go.
It's like inflating a balloon that refuses to deflate.
That's actually a perfect analogy. Intraluminal pressure rises, and here's a key concept. Veins collapse before arteries.
So venous congestion comes first, causing edema and worsening pressure.
And eventually, arterial inflow gets compromised. That's especially bad because the appendicular artery is a terminal end artery, meaning there's no collateral circulation. So once it's gone, it's really gone.
Which leads us straight into the classical sequence: ischemia, necrosis, gangrene, and perforation.
And as pressure builds and ischemia sets in, bacteria proliferates aggressively, most commonly E. coli, Klebsiella pneumoniae, and Pseudomonas aeruginosa. All gram-negative rods, many gas-producing, which worsens distension, wall stress, and necrosis.
And once perforation happens, that bacteria spills directly into the peritoneal cavity.
That's when localized inflammation turns into generalized peritonitis or sepsis.
Now let's talk pain, because appendicitis pain has a timeline, and the examiners expect you to know it like the back of your hand.
Exactly. So early pain occurs in the first 0 to 4 hours, and it's visceral pain from the luminal distension. It's mediated by T10 to T11 afferent fibers traveling via the lesser splanchnic nerve to the superior mesenteric ganglion.
Which is why early pain is vague, dull, and periumbilical.
As inflammation spreads to the parietal peritoneum, the pain becomes somatic.
Sharp, localized, and classically in the right lower quadrant.
Specifically at the McBurney's point, 1/3 of the distance from the anterior superior iliac spine to the umbilicus.
On physical examination, you'll see localized tenderness, guarding, rigidity, and rebound tenderness.
And don't forget the name signs. Examiners love these. Rovsing sign, left-sided palpation causing right-sided pain. There's psoas sign, which is pain with hip extension suggesting a retrocecal appendix. Obturator sign, pain with internal rotation of the hip, pointing to a pelvic appendix. And Dunphy sign, which is pain worsening with coughing.
I hope you focus in your pro sessions because that's a lot of signs. Labs typically show leukocytosis with a left shift. CRP becomes especially useful after 24 hours. High levels correlate strongly with perforation.
And say it with us now.
Pregnancy test is mandatory in all women of childbearing age. In adults, CT scan with contrast is the gold standard. In children and pregnancy, always start with ultrasound.
If the ultrasound is inconclusive in pregnancy, MRI is the next step. Never CT unless it's absolutely necessary. Appendicitis can be diagnosed clinically using scoring systems, and the classic one is the Alvarado score.
It uses the mnemonic mantrals.
Let's break it down. Each letter accounts for 1 point. M is for migration of pain to the right lower quadrant, A for anorexia, N for nausea or vomiting, T for tenderness in the right lower quadrant. This one gets 2 points. Then there's R, rebound tenderness, E for elevated temperature, L for leukocytosis, which also gets 2 points, and finally S, shift to the left.
So according to my calculations, the total score is 10. And I recall from third year that scores 7 or higher strongly suggest appendicitis and usually warrant surgical consultation.
Correct. There's another scoring system that's more accurate though, the AIR score, especially in adults. It incorporates CRP and objective findings more heavily, which helps reduce negative appendectomy rates.
So you just taught us the Alvarado score for nothing? Let's cover management next. Definitive treatment is appendectomy, preferably laparoscopic. Clinically stable patients can safely wait 12 to 24 hours without increased risk of perforation. Non-operative management with antibiotics may be considered an uncomplicated appendicitis, but recurrence rates approach 40% within 5 years.
And an appendicolith is an absolute contraindication to conservative management.
That's a big word. Appendicolith, basically a little stone blocking the appendix. But if appendicitis isn't treated, things can escalate quickly. We're talking perforation, abscess formation, phlegmon, gangrene, and even sepsis.
And gangrenous appendicitis can actually show air inside the wall of the appendix on imaging, right?
Exactly. That's called pneumatosis, air in the appendiceal wall, and that's a red flag.
Okay, so we've covered inflammation and complications, but here's something people don't always think about. Not every appendicitis is just inflammatory. Sometimes there's something else hiding there.
Right. Appendiceal tumors can actually present exactly like appendicitis. Same right lower quadrant pain, same labs. And sometimes they're only discovered incidentally after the appendix is removed and sent down to pathology.
So, what kind of tumors are we talking about?
The most common ones are neuroendocrine tumors, historically called carcinoid tumors. If they're small under 2 centimeters, a simple appendectomy is usually enough.
But size changes everything.
It does. Larger neuroendocrine tumors, especially over 2 centimeters, or even adenocarcinomas of the appendix, require a more extensive surgery.
Which is?
A right hemicolectomy, removing the right side of the colon to ensure proper margins and lymph node clearance.
So the takeaway is, sometimes appendicitis isn't just appendicitis.
Exactly. And pathology is what tells you the full story.
Here's a case scenario for you. A 23-year-old male presents with right lower quadrant pain, nausea, and fever. Histopathology of his recent appendix reveals mucosal ulcerations, neutrophilic infiltration, and luminal obstruction by a fecalith. Which pathophysiological mechanism most likely initiates his appendicitis? A. Bacterial invasion of the appendix. B. Luminal obstruction leading to increased intraluminal pressure. C. Ischemia due to vasculitis. Or D. Autoimmune destruction of the mucosa.
And the answer is B. The most common cause of appendicitis is luminal obstruction, either by fecalith or lymph node hyperplasia. This all leads to an increased pressure, bacterial overgrowth, and ischemic necrosis.
Great job. All right, deep breath. This is acute appendicitis. Rapid fire exam mode. If your exam is in an hour, this is what you listen to.
Okay. Rule number 1, and if you remember nothing else, remember this. Appendicitis always starts with luminal obstruction. Always.
Not inflammation, not infection, obstruction. No obstruction means no appendicitis.
And the cause depends on age. Kids and young adults, lymphoid hyperplasia, often after a viral illness. Adults, fecalis. Elderly, it's a tumor until proven otherwise.
Once the lumen is blocked, goblet cells keep secreting mucus.
But there's nowhere for it to go.
Therefore, the pressure builds, veins collapse first, and then the arteries.
And remember, the appendicular artery is a terminal end artery. No collateral circulation.
Which means ischemia,
Necrosis,
gangrene,
and eventually perforation.
all at the same time. The bacteria is multiplying.
Remember the big 3? Most commonly E. coli, Klebsiella pneumonia, and Pseudomonas aeruginosa.
Clock it. They're gram-negative, often gas-forming, worsening distension, and wall damage. Now let's talk pain, because appendicitis pain has a timeline.
Early pain, first 0 to 4 hours, is visceral pain from distension,
It's mediated by T10 to T11 via the lesser splanchnic nerve.
which is why early pain is vague and periumbilical.
Later on, inflammation hits the parietal peritoneum.
Pain becomes sharp, localized, and classically in the right lower quadrant.
Specifically at the McBurney's point, 1/3 from the anterior superior iliac spine to the umbilicus.
On physical examination, you'll find tenderness, guarding, rigidity, and rebound tenderness. Labs usually show leukocytosis with a left shift, and CRP becomes useful after 24 hours. High levels suggest perforation.
And again, say it with us because this is really important.
Pregnancy test is mandatory in all women of childbearing age.
Because it could just be an ectopic pregnancy.
For imaging, when it comes to adults, CT scan with contrast is the gold standard. Children in pregnancy, ultrasound first. If ultrasound is inconclusive in pregnancy, you can go for an MRI.
And for management,
Definitive management is laparoscopic appendectomy.
stable patients can safely wait 12 to 24 hours. Antibiotics alone can be used in uncomplicated cases.
But remember, recurrence reaches 40% at 5 years.
And an appendicitis is an absolute contraindication to conservative management. Complications include perforation, abscess, phlegmon, gangrene, and sepsis.
Gangrenous appendicitis may show air in the wall, pneumatosis, on imaging.
And for the final trap, tumors.
Carcinoid tumors that are under 2 centimeters, you would go for an appendectomy.
And for carcinoids that are more than or equal to 2 centimeters or adenocarcinoma, we do a right hemicolectomy.
Mucinous tumors are dangerous. Rupture can cause pseudomyxoma peritoni.
And that's a wrap. You guys got this. Go ace it.
Thanks for tuning in to PodBites. Stay curious, stay hydrated, and eat a pear muffin.